The topic of the tutorial is eyelids and orbital cavity, and I, Dr. Alpana Kesar, will be covering this topic under the following subheads: eyelids, extraocular muscles of the eyeball, blood supply of the structures in the orbital cavity, innervation of structures in the orbital cavity. Eyelids. These are the eyelids. Eyelids helps in protecting the eyeball. The layers of the eyelids from outside to inside include skin, which is the outermost layer. Deep to it is present a thin layer of loose connective tissue where the blood and the fluid accumulates at the time of injury. Next to that is the layer of the voluntary muscle, that is orbicularis oculi, which helps in closing the eyelids and is innervated by the seventh cranial nerve, that is the facial nerve. Deep to that is present orbital septum. This is the orbital septum which is present in both the upper and the lower eyelids. Orbital septum is the extension of the periosteum from the margins of the orbit. Tarsus. These are the tarsus. This is the superior tarsal plate and this is the inferior tarsal plate. These tarsal plates provide support to the eyelids. They are attached medially to the medial palpebral ligament and laterally to the lateral palpebral ligament. Embedded in the tarsal plates are the tarsal glands, which are the modified sebaceous glands. Attached to the tarsal is the tendon of levator palpebrae superioris muscle. The levator palpebrae superioris muscle helps in raising the eyelids. It is innervated by oculomotor nerve, which is the third cranial nerve, and also the postganglionic sympathetic fibers from the superior cervical ganglion. Loss of function, either through the damage to oculomotor nerve or to the sympathetic fibers, will result in ptosis or drooping of the upper eyelid. Conjunctiva. Conjunctiva is a thin membrane that covers the posterior surface of the eyelids. After covering the posterior surface of the eyelids, the conjunctiva reflects on to the outer surface of the sclera of the eyeball. The conjunctival sac is formed when the eyelids are closed. The upper and the lower extensions, that is this and this, of the conjunctival sac is called the superior conjunctival fornix, which is this, and the inferior conjunctival fornix, which is this. Associated with the eyelash follicles are the sebaceous and sweat glands. Blockage and inflammation of the sebaceous and sweat glands associated with the eyelash follicles is called a stye, and it occurs on the edge of the eyelids. Blockage and inflammation of tarsal gland is called chalazion and is on the inner surface of the eyelids. This is a stye and this is a chalazion. Arterial supply of the eyelids is from the ophthalmic artery through its supratrochlear, supraorbital branches and also the lacrimal and the dorsal nasal branches. It is also from the facial artery through its branch called angular artery, and also through transverse facial artery, which is a branch of superficial temporal artery. Venous drainage is in the corresponding veins. Lymphatic drainage is in the parotid group of lymph nodes and also in the submandibular group of lymph nodes. Innervation of the eyelids. The sensory innervation of the eyelids is by trigeminal nerve via the following branches: the ophthalmic nerve. The branches of ophthalmic nerve that innervates the eyelids are supraorbital, supratrochlear, infratrochlear, and the lacrimal branches. an infraorbital branch of maxillary nerve. The motor innervation is by facial nerve that innervates the orbicularis oculi muscle. Levator palpebrae superioris is innervated by oculomotor nerve. Sympathetic fibers innervate the superior tarsal muscle, which is a part of the levator palpebrae superioris. Clinical anatomy. Loss of innervation of orbicularis oculi by the facial nerve causes inability to close the eyelids tightly, as also occurs during Bell's palsy. Loss of innervation of levator palpebrae superioris by the oculomotor nerve causes inability to open the eyelid voluntarily, producing complete ptosis. Loss of innervation of superior tarsal muscle by the sympathetic fibers cause a constant partial ptosis. Medial and lateral check ligaments. This is the medial check ligament and this is the lateral check ligament. Medial check ligament is an extension of the fascia covering the medial rectus muscle that is attached immediately posterior to the posterior lacrimal crest of the lacrimal bone. The lateral check ligament is an extension of the fascia covering the lateral rectus muscle and is attached to the orbital tubercle of the zygomatic bone. Functionally, the positioning of these ligaments restrict the medial and the lateral rectus muscle, and that is why the name the check ligaments. Yet another specialized fascial sheath extending from the medial check ligament to the lateral check ligament present below the eyeball is called the suspensory ligament, and suspensory ligament helps in supporting the eyeball. This is the suspensory ligament. Extraocular muscles of the eyeball. Students, don't forget to like this video and subscribe to the channel to stay updated with the latest exam questions. Muscles within the orbital cavity can be divided into two categories: intrinsic muscles and extrinsic muscles. Intrinsic muscles are those muscles which are present within the eyeball. These muscles control the shape of the lens and the size of the pupil. The intrinsic muscles include ciliary muscle, sphincter pupillae, and dilator pupillae. Extrinsic muscles of the eyeball are also known as extraocular muscles of the eye. They help in controlling the movements of the eyeball and raising the upper eyelids. The extrinsic muscles are levator palpebrae superioris, which helps in raising the upper eyelids, and the muscles that bring about movement of the eyeball include the fore rectus muscle, that is superior rectus, inferior rectus, medial rectus, and the lateral rectus, and two oblique muscles, that is the superior oblique and the inferior oblique. Movements of the eyeball include: 1. Elevation, where the eyeball rotates upwards to move the pupil superiorly. Depression, where the eyeball rotates downwards and moves the pupil inferiorly. Abduction is the lateral movement of the pupil. Adduction is the medial movement of the pupil. Internal rotation, where the upper part of the pupil moves medially. External rotation, where the upper part of the pupil moves laterally. Levator palpebrae superioris. The muscle seen here, this one is levator palpebrae superioris. This muscle is levator palpebrae superioris. Here it is splitting into two, the superior lamellae and the inferior lamellae. The superior lamellae is voluntary and the inferior lamellae is involuntary. The origin of levator palpebrae superioris is from the lesser wing of sphenoid and also from the region of bony orbit anterosuperior to the optic canal. Insertion is as follows. The muscle splits into superior lamellae and inferior lamellae. Superior lamellae is voluntary and gets inserted on the anterior surface of the superior tarsus and also in the skin of the eyelids. The inferior lamellae is involuntary and it is also known as the superior tarsal muscle. It gets inserted on the upper margin of the superior tarsus and also in the superior conjunctival fornix. Innervation or nerve supply. The voluntary fibers are innervated by the oculomotor nerve, which is the third cranial nerve. However, the superior tarsal muscle, which is involuntary, is innervated by postganglionic sympathetic fibers from the superior cervical ganglion. The function of levator palpebrae superioris is its voluntary fibers helps in conscious elevation of the upper eyelid. That is, when we open the eyes from the closed position, the elevation of upper eyelid is brought about by the voluntary fibers. Once we have opened the eyes remains open and we do not have to maintain it at a conscious level. That is, the eyes remain open at subconscious level and it is the superior tarsal muscle that helps to maintain the eyelid elevation at all times. Clinical anatomy. Loss of oculomotor nerve function results in complete ptosis or drooping of the upper eyelid as the patient is unable to open the eyes. Loss of sympathetic innervation to the superior tarsal muscle will result in partial ptosis where the patient is able to open the eyes but is unable to maintain it open at all times and thus there will be partial ptosis. Superior rectus and inferior rectus muscle. Both superior rectus and inferior rectus takes origin from the common tendinous ring. The superior rectus takes origin from the upper part of the common tendinous ring while the inferior rectus takes origin from the lower part of the common tendinous ring. Insertion of both the muscles is in the anterior half of the eyeball. The superior rectus gets inserted in the anterior half of the eyeball on the superior surface, and the inferior rectus gets inserted on the anterior half of the eyeball on the inferior surface. This is the superior rectus and this is the inferior rectus. Here, this is the superior rectus. The nerve supply of both the muscles is oculomotor, which is the third cranial nerve. The superior rectus, that is this muscle, helps in elevation of the eyeball, while the inferior rectus helps in depression of the eyeball. Both superior rectus and inferior rectus, which takes origin from the common tendinous ring, after taking origin, the fibers run laterally and forwards. When both the muscles contract together, they help in medial rotation of the eyeball and thus helps in adduction. Medial and lateral rectus muscles. Both medial and lateral rectus muscles takes origin from the common tendinous ring. The medial rectus takes origin from the medial part of the common tendinous ring, while the lateral rectus takes origin from the lateral part of the common tendinous ring. This muscle is medial rectus, and this muscle is lateral rectus. Here, this muscle is lateral rectus and this one is medial rectus. After taking origin from the common tendinous ring, both medial and lateral rectus get inserted in the anterior half of the eyeball. The medial rectus gets inserted on the medial surface of the anterior half of the eyeball, while the lateral rectus gets inserted in the lateral surface of the anterior half of the eyeball. Medial rectus will rotate the eyeball medially and thus helps in adduction. Lateral rectus helps to rotate the eyeball laterally and thus helps in abduction of the eyeball. The innervation of medial rectus is by the oculomotor nerve, which is the third cranial nerve, and lateral rectus is by the abducent nerve, which is the sixth cranial nerve. Superior oblique muscle. Superior oblique muscle takes origin from the body of sphenoid and from the superior and the medial parts of the optic canal. This muscle is superior oblique. After taking origin, the muscle passes forwards along the medial border of the roof of the orbit till it reaches the trochlea. Trochlea is a fibrocartilaginous pulley which is attached to the trochlear fovea of the frontal bone. The tendon of superior oblique muscle passes through the trochlea and then it turns around and runs across the eyeball in a posterolateral direction. It continues deep to the superior rectus muscle and get inserted in the outer posterior quadrant of the eyeball. It gets inserted on the outer posterior quadrant of the eyeball on the superior surface. Action of the muscle is, when it contracts, it helps in the depression and the abduction of the eyeball. When the muscle will contract, it will elevate the posterior part of the eyeball and thus it will depress the anterior part of the eyeball, bringing about depression. Likewise, it will medially rotate the posterior part of the eyeball and thus it will laterally rotate the anterior part of the eyeball. Hence, it helps in bringing about depression and abduction. The innervation is by the fourth cranial nerve, that is the trochlear nerve. Inferior oblique muscle. Inferior oblique muscle takes origin from the anteromedial part of the floor of the orbital cavity. It is the only muscle that takes origin from the anterior part of the orbital cavity, while rest of all the muscles takes origin from the posterior part of the orbital cavity. After taking origin, the muscle passes in the posterolateral direction. This is inferior oblique. It passes in the posterolateral direction between the inferior rectus and the floor of the orbital cavity. Then it passes posterolaterally to get inserted in the outer posterior quadrant of the eyeball on the inferior surface. When the muscle contracts, it will pull the posterior part of the eyeball downwards, and thus it will help in moving the eyeball upwards and the pupil upwards, and so it helps in elevation of the eyeball. Inferior oblique, when contracts along with the superior oblique muscle, will rotate the posterior part of the eyeball medially and thus it will rotate the pupil laterally, leading to abduction of the eyeball. The nerve supply of inferior oblique muscle is oculomotor nerve, which is the third cranial nerve. This diagram summarizes the action of all the extraocular muscles of the eyeball and helps to remember the action of all the muscles easily. Medial rectus helps in the medial rotation of the eyeball. Superior rectus helps in the medial rotation and elevation of the eyeball. Inferior oblique helps in elevation and lateral rotation of the eyeball. Lateral rectus helps in the lateral rotation. Superior oblique helps in the depression and lateral rotation of the eyeball. Inferior rectus helps in depression and medial rotation of the eyeball. LR6SO4AO3 sounds like some chemistry formula, but this is a mnemonic for remembering the innervation of the extraocular muscles of the eyeball. The lateral rectus muscle is innervated by the sixth cranial nerve, that is the abducens. Superior oblique is innervated by trochlear, which is the fourth cranial nerve, and all others are innervated by the third cranial nerve, that is the oculomotor. These muscles do not act in isolation. They work as a team of muscles to bring about coordinated movement of the eyeball so as to position the pupil as needed. Unilateral paralysis of the extraocular muscles occur due to brainstem injury or direct nerve injury, which may be associated with tumor compression or trauma. Paralysis of the muscles is easily demonstrated when the patient attempts to move the eye in the direction associated with the normal action of that muscle. Typically, the patient complains of double vision or diplopia. Blood supply, arterial supply and venous drainage of structures in the orbital cavity. Ophthalmic artery. The main blood supply to all the structures within the orbital cavity is by the ophthalmic artery. Ophthalmic artery is a branch of internal carotid artery, as the internal carotid artery leaves the cavernous sinus. After that, the ophthalmic artery passes along with the optic nerve through the optic canal to enter the orbital cavity. In the orbital cavity, it gives off several branches. Some of the branches given off by the ophthalmic artery are the lacrimal artery, which supplies the lacrimal gland and the lateral side of the eyelid. Next branch that it gives is the retinal artery. The central retinal artery enters the optic nerve. This is the optic nerve. The central retinal artery enters the structure of the optic nerve, passes along with the optic nerve to reach the retina of the eye. Occlusion of this blood vessel will lead to blindness. Short and long posterior ciliary arteries. These are the short and long posterior ciliary arteries which supply the rest of the structures inside the eyeball. Muscular arteries are those which supplies the intrinsic muscles of the eyeball. The ophthalmic artery, after giving off the muscular branches, gives the following branches, and they are the supraorbital artery, which is this. Supraorbital artery supplies the forehead and the scalp. Further, the ophthalmic artery gives the posterior and the anterior ethmoidal arteries. The posterior ethmoidal artery exits the orbit by passing through the posterior ethmoidal foramen, and then it supplies the ethmoidal air cells and the nasal cavity. Anterior ethmoidal artery exits the orbit by passing through the anterior ethmoidal foramen and gives the following branches: anterior meningeal artery and branch to the septum and the lateral wall of the nose. The anterior meningeal artery supplies the meninges in the anterior cranial fossa. Then, the ophthalmic artery gives the medial palpebral branch which supplies the medial part of the upper and the lower eyelids. The terminal branches of ophthalmic artery are the supratrochlear and the dorsal nasal artery. Dorsal nasal artery supplies the upper surface of the nose, while the supratrochlear artery leaves the orbit by passing through the supratrochlear foramen and supplies the forehead. There are two venous channels in the orbital cavity. They are the superior ophthalmic vein and the inferior ophthalmic vein. Superior ophthalmic vein, which is this, is formed by the joining of the supraorbital vein with the angular vein. After that, the superior ophthalmic vein passes backwards close to the roof of the orbital cavity. As it passes backwards, it receives the tributaries, which are the veins of the orbital cavity. These veins of the orbital cavity correspond to the branches of the ophthalmic artery. After that, the superior ophthalmic vein leaves the orbital cavity by passing through the superior orbital fissure, whereafter it enters the cavernous sinus. The inferior ophthalmic vein. This is the inferior ophthalmic vein, which is smaller when compared to the superior ophthalmic vein, and it travels backwards in the orbital cavity close to the floor of the orbital cavity. It receives tributaries from the muscles and also from the posterior part of the eyeball. Inferior ophthalmic vein, when reaches the posterior part of the orbital cavity, may terminate in one of the following manner. Either it may join with the superior ophthalmic vein to form a common vein that drains into the cavernous sinus, or it may pass separately through the superior orbital fissure as a separate vein and may enter the cavernous sinus separately, or it may pass through the inferior orbital fissure and may join the pterygoid plexus of veins in the infratemporal fossa. Because the ophthalmic veins communicates with the cavernous sinus, thus they may act as a route by which infections from the outside may reach inside the cranial cavity. Innervation or nerve supply of structures in the orbital cavity. Innervation or nerve supply of the orbital cavity. Motor innervation of the orbital cavity is by one of the following nerves, and that is the oculomotor, which is the third cranial nerve, the trochlear, which is the fourth cranial nerve, abducens, which is the sixth cranial nerve, and autonomic nerves, that is the sympathetic and the parasympathetic nerves. Sensory innervation of the orbital cavity is by optic nerve, which is the nerve of vision and is sensory, rather special sensory, to the retina of the eyeball, and ophthalmic nerve is sensory to rest of the structures within the orbital cavity. Sympathetic nerve supply of the orbit. The preganglionic sympathetic fibers for the orbit arise from the upper segments of the thoracic spinal cord, mainly the first thoracic segment of the spinal cord. The preganglionic fibers enter the sympathetic chain and reach the superior cervical ganglion. The postganglionic fibers from the superior cervical ganglion pass as a plexus around the internal carotid artery and then its branches. The postganglionic sympathetic fibers, which are destined for the orbit, travel around the ophthalmic artery, which is a branch of internal carotid artery. The postganglionic sympathetic fibers innervate the dilator pupillae muscle that helps in the dilation of pupil and superior tarsal muscle that helps in maintaining the upper eyelid open or elevated subconsciously at all times. Horner syndrome. Horner syndrome is caused by a lesion in the sympathetic trunk in the neck. It results in the sympathetic dysfunction, which is characterized by 5 typical features. The 3 prominent features of Horner syndrome are meiosis, partial ptosis, and anhidrosis. Meiosis is pupillary constriction due to paralysis of dilator pupillae muscle. If we compare the pupil of this eye with this one, we find that it is constricted here. So pupillary constriction, partial ptosis, where there is drooping of the upper eyelid due to paralysis of the superior tarsal muscle of the levator palpebrae superioris. Anhidrosis, where there is absence of sweating on the ipsilateral side of the face due to absence of innervation of the sweat glands. So, the prominent features of Horner syndrome are meiosis, ptosis, and anhidrosis. Other symptoms are there is sinking of eyeball in the bony cavity, and there is loss of cilio-spinal reflex, that is pinching of the skin on the nape of the neck does not produce dilation of pupil, which normally takes place. Parasympathetic nerve supply of the orbit is by ciliary ganglion. This is the ciliary ganglion. It is a parasympathetic ganglion of the oculomotor nerve, which is the third cranial nerve. Ciliary ganglion is a small ganglion which is present in the posterior part of the orbit immediately lateral to the optic nerve. This is the optic nerve. The oculomotor nerve carries preganglionic parasympathetic fibers to the ciliary ganglion, and the postganglionic fibers arising from it are distributed to 1. Sphincter pupillae muscle, which is for the pupillary constriction, and 2. To the ciliary muscle for the accommodation of lens for the near vision. Ophthalmic nerve. Ophthalmic nerve is one of the 3 subdivisions of the trigeminal nerve. This is ophthalmic nerve and this is the trigeminal nerve. Trigeminal nerve divides into 3 subdivisions, that is ophthalmic, maxillary and mandibular. Ophthalmic is the most superior of the 3 and it is the smallest subdivision of the trigeminal nerve. Ophthalmic nerve is a purely sensory nerve. It innervates the structures within the orbital cavity, face and scalp. It leaves the trigeminal ganglion and passes forwards in the lateral wall of the cavernous sinus. Just before it reaches the orbital cavity, it divides into its 3 terminal branches, and they are the nasociliary, lacrimal, and frontal branches. Each of these 3 branches enters the orbital cavity separately through the superior orbital fissure. This is the frontal branch of the ophthalmic nerve, which is the largest of the 3. This is the lacrimal branch, which is the most lateral branch, and this one is the nasociliary branch of the ophthalmic nerve. Lacrimal nerve. This is the lacrimal nerve. Lacrimal nerve is the most lateral of the 3 subdivisions of the ophthalmic nerve. It is also the smallest of the 3 branches. Lacrimal nerve receives a branch from the zygomaticotemporal nerve. This branch delivers postganglionic parasympathetic fibers from the pterygopalatine ganglion to the lacrimal nerve to be distributed to the lacrimal gland. The area of supply of lacrimal nerve is 1. Lacrimal gland, to which it delivers the sensory fibers as well as postganglionic parasympathetic fibers from the pterygopalatine ganglion. It is also sensory to conjunctiva and the lateral part of the upper eyelid. Frontal nerve. This is the frontal nerve. Frontal nerve is one of the three subdivisions of the ophthalmic nerve, and it is the largest of the three branches of the ophthalmic nerve. It passes through the superior orbital fissure. After that, it traverses through the roof of the orbit. Midway through the orbit, it divides into its two terminal branches, supratrochlear and supraorbital. Through its two branches, that is supratrochlear and supraorbital, the frontal nerve supplies the following structures: conjunctiva of the eye, skin of the upper eyelid, skin of the forehead, and scalp. Nasociliary nerve. This is the nasociliary nerve. Nasociliary nerve is one of the three branches of the ophthalmic nerve. It is the most medially located branch of ophthalmic nerve. Frontal is the largest branch, lacrimal is the smallest branch, while nasociliary is intermediate in size. The branches of nasociliary nerve are the long ciliary nerves, which are these that are sensory to the eyeball. Posterior ethmoidal nerve exits the orbital cavity by passing through the posterior ethmoidal foramen and is sensory to the posterior ethmoidal air cells and sphenoidal air sinus. Anterior ethmoidal nerve exits the orbital cavity by passing through the anterior ethmoidal foramen and supply the anterior cranial fossa, nasal cavity, and skin of the lower half of the nose. Infratrochlear nerve, which distributes to the medial part of the upper and lower eyelids, lacrimal sac, and skin of the upper half of the nose. The questions that may be asked in the examination from the topic eyelids and the structures of the orbital cavity include extraocular muscles of the eyeball. A short note may be asked or a major may be asked on this topic. Students might be asked to enumerate the extraocular muscles of the eyeball as a short note, or may be asked to write a major asking to write origin, insertion, nerve supply, and action of all the extraocular muscles of the eyeball. A short note may be asked on a single extraocular muscle of the eyeball, such as superior oblique. Short notes may be asked on topics like conjunctiva, tarsus, stye and chalazion, ciliary ganglion, Horner's syndrome, ophthalmic artery, ophthalmic veins, and ophthalmic nerve.